Hello, and welcome to Fundamentals of Substance Use Disorders Care. My name is Kate Marshall, and I'll be presenting for you today. Now, before we get started, I just want to clarify that I have no financial relationships or conflicts of interest to disclose. The opinions and guidance are my own and don't represent those of any particular organization or entity. The cases have been modified and fictitious names used, and all the artwork that you're going to see is displayed under the Creative Commons license and can be found at addictionandart.org. Let's talk about what we're going to learn today. So, by the end of this session, I hope that you'll be able to describe the neurobiology of addiction and list some risk factors for developing a substance use disorder, sometimes called SUD. Be able to describe the impact of stigma on people with substance use disorders. Learn how to use principles of trauma-informed care in the management of patients with substance use disorders, and list several actionable harm reduction strategies for people who use substances. Now, as you can see, for this session, we're going to focus on the big picture. In my training, I've learned some important background information and approaches to care that really aren't talked about enough, but each of these components are part of the continually evolving standard of care in the field of addiction medicine. And it turns out that understanding these principles actually makes caring for patients with substance use disorders more satisfying and much more effective, which is why we're starting with them first thing. So let's start with a case. This is Jonathan. He's a 37-year-old man admitted for alcoholic hepatitis. His alcohol level was negative on admission, but phosphatidylethanol and ethyl glucuronide were elevated. On admission, he reports that he had about 8 years of heavy drinking at 5 to 6 drinks daily in his 20s, but then was diagnosed with fatty liver in 2011, and he managed to achieve 7 years of complete abstinence from alcohol with AA, and in the meantime, he earned his medical degree and is an MD. A year ago, however, he went through a major life stressor and returned to drinking alcohol. He was forced to leave his medical residency and isn't sure what he's going to do with his life at this point. And this is now his second admission for hepatitis this year. On further questioning, I learned that he had never engaged in residential or intensive outpatient treatment for alcohol use disorder. He's also never been offered medication treatment for alcohol use disorder. He does have a family history. His father and uncle struggled with alcohol use. He has no history of legal involvement and no blackouts or seizures from alcohol in the past. When I met Jonathan, I had a hard time comprehending how he could have let this happen. He was well educated, had a loving family, significant resources. He knew his medical risk. He knew he should avoid alcohol at all costs. But he returned to drinking even though he could lose his career, his family, and his life. And as I've studied substance use disorders, I've learned a lot more about the reasons people do what they do. Specifically, why they sometimes continue to use substances despite devastating effects on their health, relationships, and self-esteem. Because disordered motivation is at the heart of the DSM-5 diagnosis of substance use disorder. It's a clinical diagnosis made based on the effects a substance has had on the patient's thoughts, actions, and life. There are 11 criteria for diagnosing a substance use disorder grouped into a few categories. We may look for escalating or continuing use even when somebody actually wants to cut back or stop. That's loss of control. We learn whether the person has had consequences to their health, relationships, or work, or school as a result of substance use. And finally, we ask if the patient has invasive, unwanted thoughts or compulsions around the substance. This is what we call cravings. So when someone has 2 or more of these 11 DSM-5 criteria, we can officially diagnose them with a substance use disorder. But what's happening in the brain to allow a substance to wreak that kind of havoc on someone's life? Why would they still continue to use a substance despite their better judgment? Eventually, I read enough, learned enough, and spoke to enough patients to realize that there was an explanation for it. And that explanation was, the substance is survival. Now, what do I mean by that? Well, people try substances for a variety of reasons. They may be seeking relief from negative emotions. They may take a substance to enhance an already pleasurable social or sexual activity. They may need more energy or alertness. They may just be curious about what it would be like. These are all understandable reasons. The scary part is that some people seem to kind of flip a switch and lose control over their use of the substance, while others don't. How does that happen? Why can other people use the same substance without any problems? It all goes back to the fact that our brains have a hardwired way of telling us what's important. Experiences that benefit our individual or collective survival, things like food, drink, sexual stimulation, social connection, stimulate the release of rewarding neurochemicals, including dopamine, serotonin, norepinephrine, and endocannabinoids and endogenous opioids in various complex and unique combinations, and that creates a sense of rightness, a sense of reward. And the amount of that stimulation is measurable. For instance, ingesting food causes about 150% above basal dopamine release in animal models. Sexual activity increases dopamine release to about 200% of baseline. So our brains assign a kind of star rating to each experience, which in neuroscience is called incentive salience. The more rewarding the activity, the more powerfully it's encoded into memory and motivational systems. The sights, sounds, and smells are carefully recorded in the brain so that we can better seek out these beneficial experiences again and in turn have a better chance of surviving. In the natural world, a few plants have evolved to directly stimulate these rewarding neural pathways in humans, bypassing the complexity of a natural experience and going straight for the receptors. Opioid receptors evolved to accept endogenous opioids, endorphins, which help suppress pain so we can escape danger and survive. The poppy plant produces raw opium, which is about 10% morphine, and morphine is a molecule that directly stimulates the mu-opioid receptor and affects powerful pain control, and due to direct stimulation, even euphoria. Cocaine, the active alkaloid found in coca leaves, binds directly to dopamine, serotonin, and norepinephrine reuptake transporters in the synapse, and the resulting neurotransmitter excess is intensely pleasurable and stimulating. The brain's nicotinic acetylcholine receptors regulate alertness, attention, autonomic nervous system activity, and when directly bound by nicotine from the tobacco plant, it's almost like turning up the volume control on these systems. As more potent chemical analogs have been isolated and distributed over the last 150 years, it has become apparent that direct stimulation of reward pathways can confer more incentive salience than any experience or substance found in nature could do. Methamphetamine, for example, results in dopamine levels in the nucleus accumbens up to 1,200% above baseline. But the brain doesn't know the difference between an actual rewarding experience and a substance that directly stimulates the neurochemical pathway. It encodes them the same way. And in some cases, the brain may in fact associate reward and cues and memories around the substance more strongly than cues for food, thirst, sex, or social interaction because the stimulation is stronger. Disordered motivation begins to develop as the brain begins to prefer stimulation with the substance over other positive experiences. But obviously, this disordered motivation doesn't occur in every case when someone tries a substance, even if they try it multiple times. It turns out that a person's brain structure and neurochemical makeup before ever trying a substance can make them even more vulnerable to the effects of rewarding chemicals. 3 factors seem to account for most of the reason one person might develop a substance use disorder and another not develop one despite exposure to the same substance. Substance use disorders are about 50% heritable, and there are multiple candidate genes for biological susceptibility to disordered substance use. It's been shown that even without substance use in the environment in childhood, people with a family history do appear to carry receptor polymorphisms and other characteristics around reward and impulsivity that make them vulnerable to disordered motivation around substances. Trauma and stress, especially childhood trauma or chronic stress, modify the brain's reward system over time. There is evidence that chronic stress decreases dopamine receptor density, which can make ordinarily pleasurable experiences seem almost muted or uninteresting, until a substance comes along that finally creates enough direct stimulation to create reward. I've heard from patients again and again that the first time they tried their substance of choice, they finally knew what it felt like to be okay. They didn't say good or amazing or fantastic. They said okay. They hadn't known what that felt like before. Another important component is timing of exposure to substances. Encountering substances during the vulnerable period of adolescent brain growth is a strong risk factor. In fact, 50% of adults with substance use disorder had symptom onset before age 18, and 80% had onset before age 24. So we now know that when a brain is vulnerable due to heredity, changes due to trauma or stress, or is in the vulnerable period of development, the door is opened to a use disorder when that vulnerable brain is exposed to something that gives strong and significant reward. The last component in developing a substance use disorder is repetition. With repeated exposure to a substance, the pathways associated with that substance then develop tolerance, and the substance becomes a requirement to maintain a normal mood or to avoid physiologic withdrawal symptoms, which can be incredibly unpleasant. This creates a new layer of negative reinforcement around the absence of the substance. Not having the substance isn't just neutral, it's suffering, and the brain encodes that negative association powerfully as well. Once that occurs, the idea of not having the substance is perceived by the brain similarly to starvation or being deprived of water, or maybe even more intense based on what we know about the incentive salience associated with these substances. In this context, a choice to use a substance at the expense of other desires and goals begins to make more sense. Dr. Nora Volkov, an eminent researcher in the neurobiology of addiction and director of the National Institute on Drug Abuse at the NIH, put it this way: "It is difficult for people without addictions to understand that people with addictions are not just seeking to get high, but suffer a medically rooted impairment in their autonomy that thwarts their best intentions to attain freedom from drugs. It is a disease in which essential motivational and self-control systems of the brain are compromised. Medical intervention, not punishment or moral re-education, is required to restore this essential human birthright." And I think this quote really gets at the fact that while there are choices and behaviors involved in developing or recovering from a substance use disorder, having that disorder is absolutely not a choice. So, what happened to Jonathan? Well, while hospitalized, he reconnected with his old AA group virtually. The medical team discussed FDA-approved medications for his alcohol use disorder, and he was started on acamprosate. He continues to take it 8 months later with no return to use of alcohol. So how can you help? Well, first recognize that heredity, environment, and social context really matter when it comes to whether someone develops a substance use disorder. And realize that to the brain with substance use disorder, that substance is necessary for survival, and behavior will reflect that. So let's move on to our next case. So this is Logan. He's a 28-year-old man admitted for bacteremia and a septic shoulder joint, secondary to injected heroin and methamphetamine use. And he reported to me that he typically uses about 1 gram of heroin a day and methamphetamine multiple times daily as well, with his last use about 12 hours prior to when I saw him. Now, he was previously on buprenorphine and able to achieve abstinence from heroin and methamphetamine for about 6 months on that therapy. But now he's in moderate opioid withdrawal, and it started on buprenorphine, 4 milligrams 3 times a day, with oxycodone as needed for breakthrough pain. Now, the next morning, when I came in to check on him, he was curled in bed with a pillow over his head, just crying. And he said, "I never should have told you that I'm a drug addict. I'd be on a pain pump right now if I weren't. You think I'm just a junkie, you think I'm a screw-up, and I'm in so much pain." And at first I was taken aback. We'd given him buprenorphine to treat his withdrawal. We'd given him oxycodone to treat his pain. I was practicing personalized and appropriate care. Why was he putting these words in my mouth? What did he think of how I viewed him? Well, it turns out that when it comes to substance use disorders, words really matter. Because if there's one word that I feel gained meaning for me during my training in addiction medicine, that word would be stigma. But what is stigma? Well, sociologists describe stigma as the situation of the individual who is disqualified from full social acceptance. It has also been described as a spoiled identity. Now, stigma occurs when human differences are labeled, stereotyped, and then distanced from the majority, and finally discriminated against. And according to the World Health Organization, drug use disorder is the world's most stigmatized condition, exceeding criminal behavior, other mental illness, communicable disease, and homelessness. Now, there are two primary schools of thought around stigma. The first is that by expressing disapproval of substance use and substance use disorders, stigma results in fewer people with the disorder, since they risk marginalization and exclusion by using the substance. Now, this view correlates with prior sociologic study classifying stigma under the science of deviance, which was thought to be a necessary process to maintain societal identity and cohesion, separating the moral majority from the immoral minority. The other view is that because substance use disorders are defined as a loss of control over substance use, even extreme stigma is incapable of restoring that control. Marginalization, incarceration, and discrimination against people with substance use disorders may actually create insurmountable barriers to recovery that would not exist without the stigma. And this view is more in line with recent sociological study that views stigma as a critical tool in the domination and exploitation of vulnerable populations. In fact, influential sociologists Lincoln Phelan argue that applying stigma as a deterrent is only useful when the behavior is clearly voluntary, and that applying stigma to involuntary traits or behaviors is perhaps better classified as prejudice. Unfortunately, stigma against people with substance use disorders has been repeatedly demonstrated to result in worse health outcomes. A recent national survey of primary care providers found that while the majority believe that opioid use disorder is a chronic and treatable disease with organic origins, many held extremely stigmatizing views of people with the disease, reporting that they wouldn't want a person with opioid use disorder as a friend or neighbor, for example. And for every additional point a provider scored on a stigma measure, the less likely they were to actually offer evidence-based treatment in their practice or refer their patient to evidence-based care. One study of doctoral-level mental health and addiction clinicians randomized them to reading a vignette describing a case of a substance abuser or a person with a substance use disorder. Those who read about the abuser were more likely to judge the patient as deserving of blame and punishment associated with their substance use. This association was even stronger when presented to the general population using the same language. The pervasive use of morally weighted terms around substance use also amplifies patients' self-stigma. Terms like clean, dirty, abuser aren't used for patients with other behaviorally expressed conditions. Patients with substance use disorders internalize the language they hear, especially from providers, and typically report very high levels of self-stigma. In general, the higher a patient's self-stigma, the less likely they are to seek treatment for substance use disorders or remain in treatment when they do. People with high self-stigma also require longer treatment engagement to attain treatment goals compared to people with less self-critical views. Perceived stigma from providers is a major reason cited by patients with substance use disorders in a decision to leave hospitalization against medical advice. Many patients describe leaving AMA as a choice to return to a community that accepts them, rather than stay in a setting where they are uncomfortable, feel judged, and feel ashamed. So that brings us back to Logan and the perceived stigma he felt from providers, as well as self-directed stigma he'd absorbed from the community. Both were interfering with his ability to cope with his pain and threatening his ability to remain admitted for the medical care he needed. I ended up sitting with him for a while that morning, mostly just listening. We acknowledged the difficulty he was having with coping and increased his medications in response. Buprenorphine was increased to 8 milligrams 3 times a day by hospital day 3. Anxiolytics were added to his regimen, and pain medication doses were increased. He also engaged with peer support and social work in the hospital. In the end, he discharged directly to residential substance use treatment on buprenorphine and completed his outpatient dalbavancin infusions in the community. So how can you help? Well, avoid morally weighted terms, including abuse, dirty, or clean, in your conversation and your documentation. Instead, practice person-first language. Person with a substance use disorder is preferred to addict, drug abuser, or alcoholic. A drug test might be positive or negative instead of dirty or clean. And keep in mind that people with lived experience, your patients, should be free to use their own preferred self-identifiers and terms, since managing self-stigma is an important part of recovery. So here's Evan. He's a 29-year-old man with a past medical history of severe opioid use disorder with IV heroin, as well as methamphetamine use disorder and tobacco use disorder, who is admitted for sepsis of the right knee after inadvertently injecting heroin directly into the joint. He left against medical advice from another hospital just 2 days ago, then presented again with worsening pain. He's now status post washout of the joint, and his pain is managed with acetaminophen, IV hydromorphone, and oral oxycodone. Now, he was seen by the addiction medicine consult service and declined withdrawal management with buprenorphine or methadone, as well as nicotine replacement therapy, saying he'd had bad experiences with all of those. Now, on arriving to post-op care, he requested to leave the floor to smoke a cigarette. The bedside nurse declined the request, stating that he couldn't bear weight on the infected joint until he'd been assessed by physical therapy. He was also too early post-op to go without monitoring, and staff couldn't be spared to accompany him outside. He became agitated and indicated he was going to leave against medical advice, and we all attempted to persuade him to stay. The attending physician on the medicine team, the charge nurse, the addiction physician, even the administrator on duty were all in his room, basically begging him not to leave. Nevertheless, he became more and more upset, saying, "You can't stop me! You can't keep me in this room!" Now, eventually, since no one would help him go outside against medical advice, he crawled to the balcony to smoke, then returned to his room, now screaming and crying in pain from his knee. Clearly, a bad outcome. I felt horrible about what Evan went through. Even knowing what I knew, it was hard to believe that he would risk his safety and his life to smoke a cigarette. And as I reflected on what could have been done differently, I realized that Evan had been stressed to the point where reason had no effect on him. Was there some other way that I could have approached him? Now, to understand what happened, I really had to put myself in Evan's shoes. It's well understood that people with substance use disorders report high levels of childhood trauma, lifetime trauma exposure, and post-traumatic stress disorder. In fact, nearly 100% of people with substance use disorder report past exposure to at least one serious traumatic event. 83% report exposure to at least 6 different adverse childhood experiences, also known as ACEs, such as emotional, sexual, or physical abuse. And more than a third of people with substance use disorder meet criteria for PTSD. In addition, 80% of people with co-occurring substance use disorder and mental health disorders report a history of traumatic brain injury. And as you can imagine, exposure to trauma or a history of traumatic brain injury can create long-lasting effects on behavior, coping, and decision-making. Now, research and work with children and adolescents with severe trauma exposure has produced a framework for understanding the behavior seen in trauma survivors, the neurosequential model. It's a neurodevelopmental approach to behavior that was developed by Dr. Bruce Perry over 20 years ago. In this model, we see 5 states. There's the state of calm, with most brain activity in the neocortex. In this state, needs are met, and the individual is able to think ahead and plan rationally. With any perceived threat, we may move into a state of vigilance. In this state, the subcortex is activated, thinking becomes more concrete, and we may be only able to plan for the next few hours or days. In a state of alarm, we see limbic dominance. Distress is actively occurring. Thinking is emotional, and planning focused on getting through the next few hours or minutes. In a state of fear, we live in our amygdala and hypothalamus. There is extreme distress and hyperarousal. Thinking is reactive, and in a state of fear, a person can only focus on the next few minutes or seconds. Finally, we descend to terror. The autonomic nervous system kicks in, and severe distress actually impedes cognition. At this point, a human's actions are reflexive, basically oriented to meeting survival needs now. Dr. Perry's treatment model theorizes that people with a history of trauma, especially trauma during childhood, may change between these states extremely quickly, often at what seems to be a slight provocation, and as a result, they may behave in ways that seem irrational to others. So it's easy to imagine how Evan, who more than likely had a history of trauma, was in severe pain from his surgery, was in physiologic withdrawal from opioids, methamphetamine, and nicotine, and was being told he was not allowed to leave his hospital room, quickly changed states. Almost instantly, he was unable to plan beyond the next few minutes, and was focused on getting to anything that could help him feel better right that second. So in retrospect, I shouldn't have tried to reason with him. I should have addressed his basic need for safety and comfort. We might call that trying to elevate the state. Now, why is this so important, and how do we do it? Well, first of all, we know that rates of discharge against medical advice are extremely high for patients with substance use disorders. Around 25 to 30% of hospitalizations in this population end in unplanned discharge. We also know that unplanned discharge greatly increases the chance of 30-day mortality and 30-day readmission. The top reasons for these unplanned discharges, as reported by the patients themselves, are undertreated withdrawal, undertreated acute and chronic pain, perceived stigma from hospital staff, and feeling trapped in a hospital room. I think these make sense, since these are all situations that would increase arousal and panic in someone who almost certainly has a history of serious trauma and whose brain perceives a substance as necessary to survival. What has been shown to reduce unplanned discharge in patients with substance use disorders? Unsurprisingly, it's the same things we might consider to bring someone to a calmer state of mind: treating withdrawal and providing social support. And that brings us to the next point. Medical care in general is not designed to be responsive to people who have experienced trauma. As individuals, we can make small changes to our practice to acknowledge trauma and stigma, but much more will be needed before our health systems feel like a safer place for our patients with substance use disorders. As individual practitioners and as systems of care, we can then begin to anticipate triggering events or environments, restore power to the individual through choice, create safe environments, and rebuild self-worth for our patients. So what happened to Evan? Well, After coming back, he was readmitted and received medication for pain, anxiety, and withdrawal symptoms while he was hospitalized. The next day, I was able to learn more about his background. It turns out he had a history of childhood physical, sexual, and emotional abuse. He actually began using opioids at age 10 and injection heroin at age 11. He attained 10 years of abstinence starting at age 18, but had a return to use when his sister was diagnosed with terminal cancer just 1 year before I met him. He also recently left the home he shared with his partner and 5-year-old child in order to protect them from his use. And when I learned that, I thought, wow, it really wasn't just the cigarette, was it? So Evan stayed admitted for 2 days, then discharged with a plan for outpatient dalbavancin infusions, and he did complete his antibiotic course. And before discharge, he expressed tremendous appreciation for care from nursing staff, the primary team, and the addiction consult service. So how can you help? Well, first just recognize which state your patient is in during each interaction, and then support them toward calmer states by treating their pain, addressing withdrawal, and addressing their fears. Finally, you can engage with system efforts to incorporate the principles of trauma-informed care into the routine delivery of healthcare. So let's talk about Portia. She's a 31-year-old woman with a past medical history of severe stimulant use disorder with IV methamphetamine and prior tricuspid endocarditis, who is admitted for a right groin abscess at an injection site. And when I met her, she was very direct with me. She said she was planning on return to use of IV methamphetamine after discharge, but in the meantime, she wanted some narcotic anxiolytic. She reported 10 out of 10 pain from the incised groin abscess and plainly told me, "I don't need a sermon, I'm just here for this infection." When I met Portia, I was scared for her. She made it clear she wasn't interested in stopping or reducing her methamphetamine use, and yet had already suffered life-threatening consequences and was facing more. In some ways, it felt like there wasn't anything I could do for her until she showed some sign that she wanted to change her ways. But I also realized that even if she and I had completely opposite goals around her substances, that didn't mean I wasn't on her side. We could still be a team. And that's where harm reduction comes in. Because substance use disorders are chronic, relapsing diseases. There will be ups and downs. And at every point on your patient's spectrum of goals, whether that be continued use, some reductions or changes in use, or complete abstinence, you can be on their side to keep them as safe as they can be. And there are so many ways you can care for someone who is not interested in discontinuing their substance use. First, you can reduce the chance of accidental death by providing naloxone rescue kits to anyone who uses non-prescribed opioids, as well as to anyone who uses non-prescribed stimulants or benzodiazepines, since these are increasingly contaminated with fentanyl. You can frequently test for communicable diseases such as hepatitis B and C, HIV, and syphilis in anyone at risk. And you can offer all indicated medical treatments to people with ongoing substance use and not use their substance as a reason to not offer care unless there is a major safety consideration. You can provide information about safer routes of ingestion, such as avoiding injecting in the groin and neck or smoking rather than injecting. You can provide supplies for safer use, including hand sanitizer, alcohol swabs, and sterile water for injection to reduce the chance of infection. You can provide support by being there for your patient to provide care when they're actively using substances. I also encourage patients to use an overdose prevention hotline such as Never Use Alone. These types of services ask for a first name, location, and an operator will stay on the line while the person uses their substance. And if the person stops responding after using, the operator will notify emergency services of an unresponsive person at the location. It can mean the difference between life and death. Because while you may feel helpless if someone is continuing to use a substance, there are so many ways to express that you care about their life and their health, even while they're active in their use. The side benefit is that harm reduction strategies create the foundation for an alliance between the patient and the provider rather than an adversarial relationship. And when that alliance already exists, then maybe if they decide to make a change, they will trust you enough to ask for help with that too. Haven Wheelock, NPH, a nationally recognized harm reductionist, says, "Isn't harm reduction just enabling? You know what? It is enabling. It's enabling people to be healthier. It's enabling people to be connected to other people. It's enabling people to get access to health care." So we use this term enabling with substance use disorders as a negative term, but honestly, I think enabling people to be healthier, happier, and less dead is a wonderful goal. So back to Portia. In the hospital, her abscess, her anxiety, and her acute pain were acknowledged and treated. HIV, hepatitis, and syphilis serologies came back negative. We encouraged her to consider alternate routes and locations for her methamphetamine administration. We provided her information for needle exchange and a supply of alcohol swabs for skin cleansing to avoid repeat abscesses or infections. We prescribed a naloxone rescue kit on discharge. Each of these increased the chance that the next time we see Portia, she'll be free from infection and, most importantly, alive. So that brings us to the conclusion of my talk today. Before we go, I'd like to summarize a few key points. Risk for substance use disorder occurs in the setting of genetic susceptibility, a history of trauma, and exposure during a vulnerable period of development. Substance use disorder develops when the brain perceives a substance is necessary to survival and prioritizes obtaining it above other goals. Experiencing stigma from others and from oneself worsens outcomes in people with substance use disorders. And trauma-aware care, use of person-first language, and harm reduction are steps you can take toward a trusting, satisfying, and effective therapeutic relationship with someone who uses substances. Thank you.